Good evening, everyone. I'm Dr. Ankit Mistry, and behalf of Intas, it's my pleasure to welcome you all in the 10th episode of Nephro Live series. Today, we will be discussing a very interesting topic: vaccination in chronic kidney disease. To, Before we begin, it's my honor to welcome our moderator for today, Dr. Dinesh Kular sir. Sir truly needs no introduction in the field of nephrology. He has been associated with this program since 2 years. He is currently working as a chairman and head of the department of nephrology and renal transplant medicine, Max Super Specialty Hospital, Saket, Pan India. Now, I would request to Dinesh sir to introduce our speaker and a panel member. Over to you, sir.
Well, thank you very much, Dr. Ankit. Good evening, everyone, and it's a pleasure again to be here amidst the galaxy of stars as well as the field of nephrology in our country is concerned. And thank you very much for all those who have joined, who have been source of constant encouragement to us to really spread the message and awareness about how we in 2025 should be managing chronic kidney disease. So we have been over the last couple of years trying to bring home the salient features of the nitty-gritties of this entity, and it's been our endeavor to at least try and do our level best so that everyone across the country has the contemporary knowledge and we are able to deliver the best possible care to our patients who repose so much of faith in us. So, over the last couple of years, for those who have been joining on a regular basis, I'm sure you have witnessed to some of the best known faces across the country as far as the nephrology field is concerned, bringing to you their messages, bringing to you the way we should be managing chronic kidney disease, be it the very definitions of chronic kidney disease, and then, of course, the symptomatology, and then moving on to how to manage diabetes and hypertension and the mineral bone disease in a given case of chronic kidney disease. Now, today we have something very special. Last time, you may recall, we talked about some of the common mistakes which are inadvertently made by so many of us while managing this very complex entity called chronic kidney disease. And certainly we need to be very, very careful, and we need to brush up our knowledge when we are talking about the various dose modifications, and keep in mind the various drug-drug interactions. The same holds true for something as basic as preventing diseases from the point of view of chronic kidney disease, whereby it is extremely important that we prevent the various preventable diseases. And now you may argue that, okay, vaccination is something which is an integral part of everyone's basic education as far as a doctor is concerned. So why talk this about this in the context of chronic kidney disease? Well, I may caution, I may bring try to bring it to everyone's notice that we as nephrologists have a little different views as far
Yes, sir.
as the vaccination schedules are concerned. We have a lot of things to consider while we are managing our patients in the various stages of chronic kidney disease, as far as their schedules are concerned, whether the patient is a pre-transplant or a post-transplant patient, whether we can give him or her a live attenuated vaccine, and if yes, if we have to give vaccine, when do we really start the vaccination process? It has been our endeavor, and I can vouch it for almost every nephrologist of the country, that this is our endeavor, that the moment we first see any of our patients, the first thing which reflexly comes to our mind is to educate the patient and the family about the need for vaccination, and that is an integral part. I would certainly want to emphasize it. Well, why I say that we view it a little differently, I'll give you an example, and I'm sure Dr. Mahajan, whom I'm shortly going to introduce, a very dear friend and one of the best known faces in the field of nephrology in the country, is going to tell us about the vaccination protocols which we follow is is the way something as basic as hepatitis B vaccination is concerned. Our protocol, as you hear from Dr. Mahajan, are different because of the difficulty with which we can achieve the seroconversion in these patients. So many times the live attenuated vaccines are not feasible. We often get a request from our patients who are going to travel to areas infested with yellow fever that we please give us an exemption certificate, because yellow fever vaccine is actually not advisable to be given to patients who are post kidney transplantation. Well, we have a lot of other questions in mind, and all these are going to be addressed by our esteemed the speaker, as well as the wonderful panelists which we have for day. So talking first about the speaker of the day, and that's Professor Sandeep Mahajan from the prestigious All India Institute of Medical Sciences. He's professor of nephrology there, and it's been an honor to know Sandeep for the last so many decades. This goes back to our days spent together at Sir Gangaram Hospital, where he had briefly joined before he took up DMA nephrology at All India Institute. And it looks like just about yesterday, so many years have passed, and it's always a treat to know Sandeep and to learn from him, from his vast experience, which has actually made him serve as a program chair, as you can see here in the Taxila American University. A whole lot of publications, a very, very lovely, wonderful publications to his credit, and various chapters and scientific presentations in various prestigious forums across the globe. And he's been integrally associated with many landmark trials. He's an associate editor of the Indian Journal of Nephrology and a whole lot of other prestigious journals as well. And he's been actually helping the government also setting up policies as far as the Indian care in the field of nephrology is concerned. He's been a very sought after person by everyone who actually happens to know him, be it his peer group, be his the colleagues, and I can vouch for that. And certainly, he's really endeared himself to his various patients. So I think we are not going to be able to have a better person than him talking about the vaccinations in chronic kidney disease. I really wanted someone with as much of experience as Sandeep to tell us about the subject in the best possible manner. And after he finishes his talk, as is customary, we are going to be joined by four panelists. And let me first introduce, and again, a pleasure to introduce a very dear friend and someone I really hold in great esteem and awe. Another professor from yet another very prestigious institution of the country, that's Sanjay Gandhi PGIMS Lucknow. It's a treat to listen to Dr. Anupama Kaul at where, and I have had the honor and the privilege of hearing her a number of times in various meetings, both nationally as well as internationally. Whole lot of papers. Now it's well known that SGPGI is always churning out some real quality papers, and she is an integral part of this kind of research, as is she the principal investigator of many projects and various. She's a sought after person. You name it, and as far as her contribution to the field of nephrology has been immense. She is now busy organizing the forthcoming Indian Society of Nephrology annual conference, which is going to be held in Lucknow. And in fact, I really owe her a one, because in spite of being so busy, she said yes to our request and invitation, and here she is, certainly going to add value as a panelist. And next we have Dr. Raka Kaushal, another person with a lot of brilliance and lot of clinical experience. It's always a treat to interact with Dr. Raka Kaushal, who after finishing her studies from the prestigious Maulana Azad Medical College and then SDPJ Lucknow, is now for the past many years working as director nephrology and renal transplant medicine, IV Hospital Mohali, and she's really been a very, very prominent face in that part of the country. Her areas of interest has been all aspects of the field of nephrology, and has been a very, very prolific speaker, and a great clinical experience, where she is very, very well adept at performing whole lot of complex procedures within the field of nephrology. So she has had a brilliant, as you can see here, brilliant academic career. Her student days certainly fetched her as many as accolades and awards as possible. One can really see it here, and she is again a great speaker, and certainly we are going to learn a lot from her vast experience. Up next, we have Dr. Sheetal Lingade, who is really done contributed a whole lot as far as the nephrology in at Goa is concerned, where Dr. Sheetal is currently working as associate professor, Department of Nephrology, Goa Medical College, and he's also associated with Healthway Hospital at Goa. After his training from St. G.S. Medical College and KM Hospital, Mumbai, he also got trained at UCLA, California, and Tokyo, and now he is the pillar of the field of nephrology at Goa, and a very, very dear friend, someone who is very extremely helpful whenever you have any kind of problem which your patients might be facing while traveling to Goa, which is actually, you all know, is something very, very frequent. He is a big help, and does not let anyone have any kind of problem should they be experiencing one while they stay at Goa. A great academician. It's always a treat to hear Sheetal, his vast experience, and he's really been, I think, one of the best things to have happened to the state of Goa as far as nephrology is concerned. Next one, please. And last but not the least, we have another brilliant fellow. I will know a person with great innovation potential, Dr. Grish G. Reddy, who is based out of Bangalore. He's assistant professor and consultant interventional nephrologist and transplant physician. He's a course in charge fellowship in interventional nephrology, Institute of Nephrourology, Bangalore, and he is actually been now a person synonymous with interventional nephrology in this country. He has done a whole lot of service to this field, because this is in its nascent stages. We wish more and more people take up this specialty, subspecialty in a big way, and he's leading the way. He has trained so many of interventional nephrologists in the country, and he's really been very, very enthusiastic, and been actually been able to spread the message as far as this field is concerned. Not that he's not equally proficient when it comes to all other aspects of the field of nephrology is concerned. He's member of the American Society of Diagnostic and Interventional Nephrology, and he's the one who took lead as a nephrologist as far as the creation of snuff box radial artery is concerned, which gives a person whole the entire almost arm for the technicians to use when it comes to doing the dialysis of a given patient. So numerous publications to his credit, and as I said, his department has really become the main one where more and more people would love to go and get trained in the field of interventional nephrology. So this is it, and with this introduction, I would now request Dr. Sandeep Mahajan to share his presentation, and I'm sure, audience, you are in for some very, very knowledgeable feast over the next an hour or so. Thank you once again, Sandeep, for accepting our invitation, and over to you now for the subject.
Yeah, good evening, sir. Good evening, everyone. First of all, obviously, my sincere thanks to Dr. Khula for one, giving me this opportunity, and for two, giving such a wonderful introduction that really, actually, I had to believe that it's being talked about me. Sir has been a luminary in nephrology, and we all have been learning and continuously getting motivated from him to take up new challenges, to take up new avenues, to improve the services in nephrology. So, and obviously, the galaxy of co-panelists I have today I think so. We should be dealing a lot about the practical aspects about vaccination in CKD. I will just start the ball rolling by giving you some basics about the uh, vaccination, about the issues in chronic kidney disease, and what are the current regime which we follow in our clinic. Subsequently, in the panel, we can discuss about so many more things, so many intricacies about vaccination in CKD, which we can have subsequently in the panel. So, in next 15 minutes or so, I would be just briefly talking about the immune system. I would be talking about the effect of chronic kidney disease on the immune system and why patients with chronic kidney disease become more prone for infections. A few slides about the vaccination, the types of vaccination, the type of immunity they give. I would be talking about specifically the vaccination schedule which we routinely follow in our clinic. And very briefly, two slides on the vaccinations before the upcoming frequently used anti-complement therapies and vaccinations in transplant patients. So it's just a very basic slide. All of you would be well aware of this, that we basically would have two types of immunity. The innate immunity, the one which we are born with, and acquired immunity is what we acquire subsequently after our birth. The acquired immunity can be active or passive, passive being coming from preformed immunoglobulins, which can be either with the immunoglobulins which we give as therapy or from the maternal, fetal-maternal route. Active immunity is what we are more concerned about today. The active immunity can either come naturally, and that would be from exposure to various antigens and infections, and it could be artificial in terms that it could be subsequent to what we are talking about today, and that is vaccination. So, a few basic differences about innate immunity and acquired immunity, besides one being the inherent immunity. Innate immunity acts as a first line of defense against all microorganisms. It is broad spectrum, non-specific, has an immediate response, but unfortunately has a very short-lived action and has no memory. Acquired immunity, on the other hand, builds up in few days, is long-lasting, has a memory, and is specific for antigens. So, unlike innate immunity, which would be broad spectrum, non-specific, acquired immunity is specific. So, this cartoon basically tells us the important players in innate and acquired immunity, adaptive immunity. The innate immunity predominantly is either by the epithelial cell barriers like the mucosa and the skin, the phagocytes, the natural killer cells, the dendritic cells, and the complement system. So these are the important players in innate immunity, while the adaptive immunity occurs subsequent to activation of either T or B cells by the dendritic or antigen presenting cells or by antigens, which leads on to proliferation and then subsequently formation of T helper cells, leading on to B cell proliferation and antibody formation, as well as lysis of the antigen. Though these two types of immunity seems to be compartmentalized, but that's not the case. They are actually very closely linked to each other, and we have players which would have an important role in both forms of immunity. Important being the natural killer cells, the dendritic cells, which are basic role of antigen presenting cells for the acquired immunity, but more importantly, the cytokines. So cytokines basically acts as an interlink between the innate and the acquired immunity. And these pro-inflammatory cytokines lead on to activation of T and B cells and subsequent enhancement of acquired immune response. So it's not that we are talking about two separate compartments. These are two compartments which act in conjunction to each other. We have innate immunity, which would act immediately, and then it would boost up the acquired immunity to build up the immune response against the perceived threat. So this is one very important factor once we talk about vaccinations. Now, coming on to the effect of chronic kidney disease on the immune system, we all understand that chronic kidney disease leads on to significant alteration in the normal milieu. This is predominantly mediated by the uremic toxins. So, There are multiple uremic toxins which get accumulated once you have progressive renal disease, and they adversely affect almost all the aspects of the immune system, whether we talk about the innate or the acquired immune system. Other than these toxins, you would have increased reactive oxygen species and the oxidative stress, which again would lead on to suppression of the immune system, and certain acquired factors like nutritional deficiency, malnutrition because of therapy, and use of various immunosuppressive drugs, which actually is quite common in patients with chronic kidney disease or in patients with renal diseases. So, this multiple factors lead on to significant alteration in the immune system, particularly the altered cytokine profile and the lymphocyte subset. So, you would have higher proportion of T helper cells as compared to T regulatory cells, and we have a unique immune dysregulation. Chronic kidney disease is a pro-inflammatory state. So all the inflammatory markers actually are hyped up in chronic kidney disease. But at the same time, it is an immunosuppressed or an immunocompromised state. So there is a state of continuous immune activation in chronic kidney disease because of multiple factors which I've eliminated. But on the other hand, when they are exposed to a perceived threat or an antigen, the immune response is not that robust. So, this is one very important paradoxical effect of chronic kidney disease on the immune system, that we have a pro inflammatory state along with an immunocompromised or an immunosuppressed state. As I said, the effect of chronic kidney disease is pan immune system, both in the innate and the adaptive immune responses. And not surprisingly, after cardiovascular diseases, infections is the second most important cause of death in patients with chronic kidney disease across all stages. And if we look at only end stage kidney disease patients, nearly one third of these patients die because of infections. And this is data from the USRDS. In India, I believe that this figure would be easily a majority. So, majority of patients with end stage kidney disease actually die of infections rather than anything else. Now, coming on to the vaccinations we all know is actually a marvel of science. It's around 230 years back when Edward Jenner introduced the cowpox vaccine for smallpox. And since these 230 years, vaccines have been used to treat, cure, and to control various epidemics. Lot of diseases have been either eradicated or controlled because of the vaccines, and they are nothing but short of being marvel of medical sciences. And this is what is the mechanism of vaccination. So this would help you understand what really happens to the immune response in chronic kidney disease. So just like a normal antigen, the vaccine antigen or an adjuvant would stimulate the dendritic cells to activate the T cells, the specific T cells, and this would lead on to activation of T cells, which subsequently downstream, with the help of T helper cells, lead on to formation of uh, plasma cells, which would secrete antibodies, as well as formation of memory B cells. The adjuvants can also directly activate the nave B cells, and this would again lead on to a similar response. Most importantly, once you have memory cells because of the vaccination, secondary immunization or use of a booster or an infection, exposure to an infection, would lead on to a prompt secondary acquired immune response, which would counter this infection. So this is how the vaccination would act. Dr. Khuller did touch upon this a bit. We would have various types of vaccine. We started off with live attenuated or killed vaccines, and now we have a whole lot of vaccines, which would be either subunit vaccines, which could be conjugated polysaccharide vaccines. We all know about COVID vaccines, which was such a hype in medical information. And we now have nucleic acid vaccine, we have viral vector vaccines, in which a small genome of that particular organism is put either in a viral vector or a bacterial vector. And then we can have various virus like proteins and outer membrane proteins, which can expose the person to specific antigens against which the antibodies and a viral and an immune response can be hosted subsequently. Now, coming on to the topic of today, and that is vaccination schedule in CKD. The patients who are suffering from chronic kidney disease, besides being more immunocompromised, are actually also more exposed to blood-borne and hospital-acquired infections due to repeated visits to the hospital. Because of the poor immune response, they would have suboptimal response to the vaccinations, as they would have poor antibody production and impaired T cell responses. And as I highlighted, because they are immunocompromised, they are increased risk of having side effects because of live attenuated vaccines. And this would be specifically true for patients who are on immunosuppressive agents, along with suffering from chronic kidney disease. Now, just moving on to specific vaccinations which we routinely recommend to our patients. The first, again, sir would have thought about is hepatitis B vaccine. So, the prevalence and incidence of hepatitis B vaccine has come dramatically. Hepatitis B actually has come dramatically down in last decade because of universal or near universal vaccination of all our CKD patients with hepatitis B vaccine. Historically, we had around 7% or 10% patients who had hepatitis B, and every year around 3% new patients were added. But with better screening of blood products and vaccination, this incidence and prevalence has come down. We have two types of hepatitis B vaccine: the plasma derived vaccine, which is no longer marketed that much now, and the more preferred recombinant DNA vaccine. However, because of the poor response the CKD patients have to the various vaccinations, instead of 3 standard shots of hepatitis vaccine, which is recommended for general population, we recommend 4 double shots of hepatitis B vaccine for all patients who have a GFR of less than 30. So instead of 1 ml, we give 2 ml of hepatitis B vaccine, and we give it 4 times: 0 T3, 0, 1, 2, and 6 months. In addition, we basically assess the response by looking at the anti-hepatitis B titers yearly in these patients and give a booster of hepatitis B, which again would be 2 ml, once the titers are less than 10. The other important disease which we can cover with vaccination is pneumococcus. The burden of pneumococcal infection is pretty high in patients with chronic kidney disease. And specifically, we have patients who would have more disseminated pneumococcal infection or serious pneumococcal infections like pneumonias and meningitis. So, though the pneumococcal vaccines are expensive, most of the patients do complain that this is an additional expense which they would have to pay or they would have to bear. But the cost benefit of a pneumococcal vaccine is definitely there for CKD patients, as most of the pneumococcal vaccines are most efficient in preventing a severe infection, an invasive disease. So you might have a milder mucosal infection after vaccination, but you would be protected against more severe infections, especially pneumonias and meningitis. There are two important pneumococcal vaccines. In fact, there are three important pneumococcal vaccines which are routinely available in the market. The polysaccharide 23 valent vaccines, the conjugated 13 vaccine, and the more recently launched, which has been here for around 3-4 years, is a conjugated vaccine with 20 strains. So, as the name would suggest, that they are either conjugated or a polysaccharide vaccine with multiple strains. So, what are the basic advantages of a polysaccharide 23 vaccine? Obviously, it covers 23 serotypes. It has a decent efficacy. It's less expensive, and it gives good protection in the elderly. The disadvantages being that it does not lead on to any T cell memory, any T cell response. The response usually declines in 5 years, and therefore you would have to repeat the dose in 5 years. It is less immunogenic. It has absolutely no effect on nasopharyngeal carriage. So, in children, if you give this vaccine, it's unlikely that you would prevent the carrier state of pneumococcal, and you can still have a community infection of pneumococcal if you give it in children. And therefore, it gives minimal or no protection to upper respiratory tract infections. While the conjugated 13 vaccine gives a robust T cell dependent response, gives you lifelong immunity, mucosal protection, good efficacy, and therefore it's better in children and preventing a community spread. Obviously, it is expensive and has a small serotype coverage. The PCV20, which is now available, would do away with this lesser serotype coverage, but it would still remain expensive. So, what do we recommend currently? We recommend that all adult patients should first be given a conjugated vaccine, followed 8 weeks later by a polysaccharide vaccine, so that we have the advantages of both. Another infection which is routinely covered in our vaccination schedule is influenza vaccine. We know that influenza is a sporadic viral illness with potential for epidemics and pandemics. And it has a peculiar pattern. The antigens would keep on shifting and drifting, like we saw with the COVID. Also, the infection, the immunity subsequent to vaccination lasts only for a year. And it does not have a huge efficacy. It would have an efficacy of only around 50%. And again, the strains and the timing of vaccination would be different, even in the aspect of the country. As I've tried to highlight, that every part of the country would have a different flu season, as we call them. And therefore, the timing of vaccination has to be 2 months prior to that perceived flu season. And therefore, like in Delhi, if we are there, best time to vaccinate for us would be just at the start or the end of monsoon, that is July and August. While if we are looking down south, we would be looking at the time to vaccinate to be October or December. So there are two strains available for this vaccine, the northern and the southern hemisphere. The southern hemisphere predominantly deals with Australia, and therefore that strain comes earlier as compared to northern hemisphere, which predominantly deals with Europe. So, as always, because the CKD patients are more exposed to influenza and subclinical exposure, and they suffer from higher influenza-related mortality, it is recommended that all patients with CKD, especially those on dialysis, should be vaccinated with the inactivated surface antigen vaccine. And this has to be done every yearly. And as I said, preferably before the start of flu season. And now we have tetravalent vaccines which are routinely available. The other vaccine, the other disease which we are really worried about is herpes zoster. Herpes and post-herpetic neuralgia greatly reduce the quality of life. And this, as you go to US, you would have these advertisements repeatedly. It's true that you can never actually, unless you experience it, feel what a hepatic neuralgia pain is like. And a persistent post-hepatic neuralgia can be a huge, huge problem subsequent to an acute hepatic zoster infection. Patients with chronic kidney disease are immunosuppressed and therefore they have a higher occurrence of herpes. They also have higher occurrence and more severe post-herpetic neuralgia, and they also have higher chances of multidermatomal and disseminated herpes. And therefore, it's a no-brainer that most of these patients should be vaccinated for herpes zoster. The problem obviously is that more easily available vaccine is a live attenuated vaccine, and therefore it becomes a problem because you would have higher chances of a risk-induced zoster, especially in an immunocompromised patient. It's cheaper and you only have to give a single shot. That's the advantage. But again, in general population, you give it only beyond 60 years because of the risk of waning with age and activation of zoster. Shingrix, which is a recombinant vaccine, is costing around 9,000 rupees. But again, you have to give two doses, which would be around 3 months apart. And this gives you a much robust protection against zoster as well as post-herpetic neuralgia pain to the tune of around 90% for both. And it has no risk of inducing zoster. So if the patient can afford Shingrix or the recombinant vaccine should be given in patients with chronic kidney disease. And in case they can't afford, then a live attenuated vaccine can be given. But the caution is live attenuated vaccines are not to be given post-transplant. So if you have to vaccinate a patient with chronic kidney disease with Shingrix or herpes zoster vaccine, it preferably has to be done pre-transplant rather than post-transplant. Another because we vaccinate at least four, we give four vaccines. Another common question which the patients do ask is, should we space in between the vaccines or they can be taken simultaneously? As a rule, unless you are giving two live attenuated vaccines, you can give two vaccines simultaneously. For two live attenuated vaccines, the ideal spacing should be around 4 weeks. However, one point you have to understand is once you are giving two vaccines simultaneously, whatever type of vaccines they might be, it's better to give on different sites because giving them on the same sites is likely to reduce the efficacy of both the vaccines. So this is the vaccination card we have for all our patients with chronic kidney disease at All India Institute of Medical Sciences, New Delhi. And this essentially talks about what I have told you about today. We vaccinate for four important diseases, and this is the schedule which we give to the patient so that it's easy for us as well as for the patient to understand the subsequent vaccination schedule. Another new challenge which has come up in field of nephrology is the use of anti-complement therapy. We have so many anti-complement drugs which are now available. Eculizumab has been there for some period of time, and multiple drugs molecules are now available for treating so many so many nephrological conditions. So two important vaccines which need to be given prior to giving this therapy. One is H influenza, and the other one is a meningococcal vaccine. So they both are conjugated vaccines, and preferably they both need to be given 14 days prior to start of these agents or prior to splenectomy, as it is said. And they are usually safe. The only thing about meningococcal vaccine is you basically have four important strains of meningococcal vaccine. The commonest is A and C, and we have quadrivalent and pentavalent vaccines which are now available. The only difference being that Menveo is the preferred one because it can be easily, though it's a conjugated vaccine, it can be easily given with all other vaccines without the break-in period. And again, it covers all the common types. A line about the vaccination in renal transplant recipients. All renal transplant recipients can be given age-appropriate inactivated vaccinations as recommended for general population. They should not be receiving live vaccines post-transplant. Dr. Khuller highlighted our inability to give yellow fever vaccine in our patients who would be traveling to endemic areas and who have undergone a transplant. If you have given a live vaccine, like if you have given a varicella zoster vaccine, which is live, you should wait at least 4 weeks before the patient undergoes a transplant. And for all routine vaccinations, because the level of immunosuppressants are high in the first 3 months, we actually wait for at least 3 months before starting vaccinations in renal transplant recipients. So just to conclude my brief talk, chronic kidney disease patients are more prone for infections, and knowledge of vaccinations are very important in managing these patients and decreasing their morbidity as well as mortality. We have to understand that we have to alter our vaccination schedules because they have suboptimal response to vaccines. Dr. Khuller did highlight this point that the earlier we vaccinate, the better is the response. So for us, the time of vaccination is the first contact. The moment patient comes to us, we give them that vaccination schedule card so that the patient has maximum chances of developing antibodies or response to that vaccine. Robust consensus guidelines are now available, so it's not a gray area. It's pretty clear as to what vaccinations we have to give. And obviously, we have challenges of new anti-complement therapies as well as post-transplant state. Thank you.
Thank you so much, Professor Mahajan, and I'm sure, ladies and gentlemen, everyone would agree it couldn't have been any better. So, what a wonderful way of giving a concise knowledge to all of us. The way we should be looking at vaccinations in CKD, something very, very important and should be an integral part because we, as yet very amply highlighted, lose majority of our patients to chronic kidney disease. And ladies and gentlemen, let me sensitize to the topic because of one reason that look, if we are able to timely vaccinate the patients against hepatitis B, it's a great news because our patients will find it very difficult to form antibodies against hepatitis B. With worsening chronic kidney disease, it becomes extremely difficult. That is why, as Dr. Mahajan had suggested, we need to give them 40 micrograms, which means 2 vials every time, and not 0, 1, 6, but 0, 1, 2, and 6, which means 4 doses of 40 micrograms each time. And even after that, there are just about 60% chances that our patients will get protected, and 30-40% chances they'll still be vulnerable. But look at what happens if they ever get hepatitis B. Our patients are on dialysis will find it extremely difficult to eradicate the virus. I mean, virtually a very, very difficult thing to achieve. Just about 20% will be able to clear the virus. And supposing tomorrow they are going to go ahead with transplantation, there is just 1% chance that they will ever clear their bodies of the virus. So that's the importance. And we have to, as nephrologists, as physicians, be mindful of the fact that we can certainly contribute a lot through vaccines. Dr. Mahajan also talked at length about the pneumococcal vaccines. And again, I would like to highlight a point that this has been the traditional way of our advocating pneumococcal protection to all our patients. But fortunately, and it's been a little confusing, patients would come that, okay, I was supposed to take a Prevnar 13, and then 2 months later, Pneumovax 23, and then 5 years later, one more time. Our job has been made rather easy with the availability of Prevnar 20. It is just now once in a lifetime vaccine, which they have to take again a conjugate, which they have added another few strains against. It works, if I remember it correctly, it is against 11, 12, 18, and 33 in addition to what Prevnar 13 was offering us. So very great innovation. But again, people are going to ask that last year we had taken Prevnar 13. Now that you say Prevnar 20 is available, what do we do? So, but please refer to, there are guidelines available. This is going to be a little out of preview of our discussion because time is very short. And may I now at this stage invite Dr. Anupama. I'm sure, Dr. Kaul, you will testify to the fact that we have a huge responsibility on our shoulders, first as nephrologists, and the kind of knowledge dissemination which we have to do to the various physicians listening to us, and they are going to be equally responsible to spread this awareness and message. So how would you say that we can improve the vaccination rates? You know that in spite of so much of enthusiasm with everyone, with us as nephrologists, we still fail miserably when it comes to actually translating into success. So how would you, and taking a cue from what you at SGPGI are doing to promote this awareness and actual vaccination drive, what is your message to begin with before we go in for more detailed discussions?
Thank you for the introduction. And what I want to highlight here is that in the institute like SGPGN and of course at All India Institute, what Dr. Mahajan was trying to highlight, we as these premier institutes always feel that these patients need to be made to understand and remove the misconceptions. So here, the hospital-based vaccination schedule program and the, of course, the understanding and removing the misconceptions is also important. And interestingly, we also highlight while they come for us for the first time, we introduce them and get them evaluated, especially the hepatitis B titers. We try to get them. And when we were looking, we've been doing one of the studies in our hospital, and what we interestingly we saw that almost 10% of the patients when we was tested them for the first time had NTH based titers be positive. So what is important to understand is because they are being vaccinated, small young children are being vaccinated as a part of the hospital schedule. So this is very important. We try to explain the complications which can happen and the risk of mortality which can happen to these patients if they acquire this infection subsequently over the period of time. Here the nurse based understanding and the poster presentations do make a role. Here the importance arise as a collective efforts both by the treating physician, students, as well as the paramedical staff.
So excellent points, and I think need to be incorporated by each one of us. And again, I would say in the context of hepatitis B, our vaccination drive actually starts with the vaccination of all the paramedical of the doctors as well as the paramedical staff. And we strongly believe, and that of course, as Dr. Mahajan had said, at least more than 10 is the titers in mind, but we always insist on everyone having a titer of over 100, which is certainly more protective, and that's something very difficult to achieve. And so many times we have to remind each one of us as doctors, as paramedical staff, technicians included, to remind each and every one of us as well as the patients, whether, because as I said earlier, it's not a good thing to have hepatitis B, especially in our patients of CKD. So moving on, Dr. Grish, this is for you. There are always myths and false notions associated with vaccination. We heard a lot about the same thing when we were wanting desperately to vaccinate people against COVID-19, and whole same holds true with where our vaccination drive takes as a hit. So how often do we as clinicians miss vaccinating, because we are all the time more concerned about the symptomatology of patients sitting in front of us? And do you agree that vaccination drive takes a backseat in our clinical practice? Over to you, Dr. Girish.
First of all, at the outset, I would like to thank Dinesh sir to make me part of this elite panel, and then Intas for this great initiative. Then our job has been made very easy by Mahajan sir's talk. So coming to this mixed vaccines and in this thing, I think it is very, very common, sir. I think I'm very sure in our OPDs we see around 30 to 40 patients sometime at a stretch. Overall, the real world data itself, even in the most advanced countries, they show that the vaccination status is below 50% in the advanced countries. When it comes to lower and middle income settings, I think it is much, much lesser. As you rightly said, for us, the perception is that vaccination means only hepatitis B, and majority of the other vaccines are not actively pursued. So I think it should be incorporated in every CKD clinic that once the patient is diagnosed with CKD, we need to have that schedule of vaccinating. So we actively do in our institute, where Hep B and all the other Indian Society recommendations of vaccines is followed. And then most common things is some misconceptions. So many of them, they have the false conception that vaccines are unsafe in kidney disease. Then the second thing is that we wait till the initiation of dialysis to vaccinate these patients. But the real fact, as Mahajan sir has rightly put out, is majority of the vaccines we use in CKD are inactivated. So they're absolutely safe across all these CKD stages. And the most important point I think we should drive forward is that vaccinate them once they are diagnosed with CKD, because the response is much, much better, rather than waiting for the patients to start dialysis, or where the response is lower. And then the other thing is the awareness about the childhood vaccinations, like, what is their vaccination status. I'm sure we all of us agree that 90% of us, we don't know what is the childhood vaccination status. So in this context, I think it would be safe to treat everyone as unvaccinated, and stick to the Indian Society of Nephrology and the CDC consensus guidelines on the vaccination.
Thank you very much. That was very insightful, Dr. Girish. And Dr. Rakha, extending what the point which Dr. Girish made, that people generally miss the bus vaccinating the people at the right time, because by the time they come to us as nephrologists, they are obviously in the late stages of CKD. We struggle to give them that kind of protection, which could have been easily done had we acted early. How often in your practice do you see that patients are totally vaccination naive? They have absolutely no knowledge about the vaccines, the our ability to prevent a whole lot of common infections. And what are the common areas where you believe our educating them can make a huge difference? Yeah.
Yeah. So what I feel is that we as nephrologists, generally the patients themselves are referred quite late to us by the physicians. So since they are referred late to us, I think most of the patients who come to me from physicians who have not come through nephrologists for a second opinion, the naive patients, almost 90, more than 95% are not vaccinated. Even the basic hepatitis B vaccination has not been done by the physicians. So that is, and since the referral is late to us, patients generally will come beyond a creatinine 2, 3. So if they're already immunocompromised, and even if we start vaccination, then I don't think that is going to really help as much as if the patient would have been referred to us earlier. So a lot of naive patients. And I also feel that even those patients, that 5 to 10% who are vaccinated, have not been given the appropriate doses, like the double dose of hepatitis B has not been given. So that is one thing. And I also feel that thirdly, that very few percentage of patients who are vaccinated and have received even the lower dose, the antibody titers, the protection has not been checked. So it is, we just vaccinate and we do not check whether those levels have been achieved or not, and we assume that they are vaccinated. So I think definitely early referral will definitely help, because I think very few, I don't think there is hardly any nephrologist who would not vaccinate the minute the patient comes. But since they are referred late, we are already late.
So such fantastic points. I would totally agree, Dr. Raka. And I think we of course, as I said earlier, so many times we miss. And even if we remember to tell them about the need for vaccination, we at times totally forget about the revaccination or the second doses. So that creates a lot of confusion. So my question to you, Dr. Sheetal, is supposing it happens, and it happens, let me admit, it happens very, very commonly. I mean, with great passion, we would advocate hepatitis B and other vaccines. They would take the first dose right there in front of you and then totally forget about it. Now the patient comes back to you after 4 months for his or her routine visit, and you realize that the patient has not taken the subsequent. What do you do with these? And I think taking Dr. Raka's point further, that we don't seem to check the titers at all. So what is your strategy? So these are the practical things which we want to learn from you as to, and this is something very, very common which happens. Yeah.
So, as you rightly said, we may initiate the vaccination schedule, and we may give them dates. We in our unit have a vaccination schedule, as Dr. Sandeep had shown the scheduler from AIMS. So we give them the dates for vaccination. Sometimes most of them would follow, but yes, you'll have many of them who will take the first dose and may not follow for the second or the third one. But yes, whenever they come with a missed dose, we ask them to take that dose. We don't ask them to begin from the first dose again. So we ask them to take the missed dose and then be on the track and be regular on the third dose and then complete the fourth dose as far as hepatitis B vaccination is concerned. So we obviously reinforce the fact that the vaccination schedule and not missing the dose is very important, especially for a dialysis patient. And we also make it a point that you need to ensure that they are seroconverted. So after the 4 doses of hepatitis B vaccination are completed, 2 months later, we check their antibody titer and ensure that they are seroconverted, expecting more than 10 units of the antibody levels. And we make it a point that we check it annually. So at least once in a year, it is essential for all of us to check the antibody titers, because as we know, the antibody response does not stay lifelong in our CKD population. They will lose their titers very quickly. In some studies, they have checked it every 6 months, but at least once in a year, we would want to check the antibody titer and ensure that they are in the protective range. If not, then give a booster to those who have falling antibody titers.
Well made points, Dr. Sheetal. Thank you very much. And I think Dr. Raka had raised a very, very important point. Now, even if, and as I alluded to earlier as well, even if we are able to give them 4 doses, double the dose each time, still we struggle to have the desired kind of antibodies. Forget about 100, even more than 10 becomes difficult. So we as nephrologists have evolved. We have various strategies whereby we have been giving repeated doses. We have taken the help of GM-CSF. We have taken the help of intradermal, and I'm talking in the reference to hepatitis B. So with that in mind, Dr. Akha, please elaborate as to what kind of various strategies do you have in mind trying to offer protection to these patients with CKD?
Yeah, so like Sir rightly said, firstly, we will give those 0, 1 to 6 doses, and after maybe 4 to 6 weeks, we will be 4 to 8 weeks, we'll be measuring the antibody titers. And if they are less than 10, then the recommendation is that you revaccinate, you repeat the entire schedule again. Now, after completing another 6 months, 0, 1 to 6, after 8 weeks, again, if the patient is not having the protective levels, then of course, intradermal and GM-CSF people have been trying. But despite that, we can only increase maybe 10 to 20% of patients who again become responsive, have antibody levels. If despite all this, the patient has not developed antibody levels, we call them susceptible patients. And the only thing left is that they need more aggressive monitoring. If they're on dialysis, you do a monthly HbS antigen, try to keep more strict infection control practices. And if they are pre-dialysis, then again, an annual anti-HbS and HbS antigen testing. But definitely, we can try GM-CSF and intradermal injections. Will partly, to a very small extent, to 20% patients may become negative.
So those who have joined us today, so this is something very interesting. We tend to give them GM-CSF 300 micrograms a day prior to the next dose of hepatitis B vaccine, and that has been shown to enhance the seroconversion. And also we've been using just 5 micrograms. I'm sure everyone remembers that it's a 20 microgram vial. So we tend to give them 5 micrograms intradermal every week. And this also, as Dr. Aka had pointed out, has the potential to enhance the capacity. Another very interesting question often asked by the patients, Dr. Anupama, is that, look, I've had herpes zoster in the past, and now everyone, starting from Mr. Amitabh Bachchan, is advocating the use of Shingrix vaccine. So should I be the one taking this vaccine? Does it really help? Dr. Mahajan very nicely alluded to the fact as to why we should be more worried about herpes. We see a spurt of herpes zoster, and that's terrible to have. The neuralgia stays with our patients. Fortunately, we have graduated from beyond Zostavax to Shingrix now. That's a huge improvement. Certainly costly, but I think cost will take a backseat when it comes to the potential benefits which we have. So your take on a patient who has already had herpes zoster in the past is now vulnerable because of the various things. Patient could be, of course, is a patient of CKD, that makes him vulnerable, is on immunosuppressions, is now planning a transplantation, or has already undergone a transplantation. So what is your take? Should they also be vaccinated?
Actually, it's a valid question because there are two things into it. One is we see that patients who have had zoster in the past, in a CKD population, there are increased risks to have zoster again in about 30% of the patients. The worst part of these things are that they lead to increased complications, and the complications tuned to the mortality. It's about 35% of the patients get hospitalized, and roughly about 50 to 20% of the patients have a high risk of mortality. So understanding this in mind and understanding that the cost is a small amount, but what is important is the outcomes. So it is wise enough to vaccinate these patients with Shingrix, and it just requires 2 doses about 2 to 6 weeks, 6 months apart. We should give them as a part of the protocol for vaccination. Another question which comes into mind, a lot of people ask, they have already been exposed to chickenpox, and then what is going to happen if they have a zoster? Should they be vaccinated? But well, then, despite if a patient has had a chickenpox exposure or had a chickenpox vaccine in the past, he still needs to be vaccinated with zoster after, and these vaccinations should be given much before they become end-stage renal disease.
Well, thank you very much, Dr. Anupama. Dr. Grish, do you think, as we are discussing today, the vaccination in the context of chronic kidney disease or transplantation, do you think we need to have separate guidelines? And that's the reason why we wanted to send this strong message to everyone who has joined us today. And is the government or the authorities also are taking action in that direction? And have they come out with some different kind of guidelines?
Uh, I think the first part of the question, do we need guidelines? Absolutely, yes, sir. I think Mahajan sir's talk beautifully answered that question. The second thing, if not for the for making it easier for the vaccine administration, the guidelines definitely will bring more attention of the vaccination concept to the CKD patients. Absolutely, yes, the guidelines should be there. I think now, thankfully, we have ISN guidelines on vaccinating our patients, which is easily available. And the second point is these guidelines are getting updated, especially with regards to the COVID vaccination. The newer guidelines recommend COVID booster doses in CKD population. So definitely, yes, we need the guidelines for sure. And then some modifications in CKD patients, like Sir has highlighted. One is giving the booster doses of PPSV 23 after 5 years. Then some attention with the live attenuated vaccines. And most importantly, now this anti-complement therapy or the immunosuppressive therapy is very often in our glomerular disease patients. So considering all these things, I think we should have new guidelines, and there should be more awareness drive. And I think physicians are the real load players, and they should be focusing more on vaccinating our patients. The earlier, the better it is.
Now, when we talk about chronic kidney disease, we are in the same breath also trying to look at the possibility of them undergoing a successful transplantation. There again, the timing of vaccination makes a huge difference, because if we are planning a transplantation, let's say in the next 1 month, we may not be really wanting to vaccinate because we know things are going to become difficult. A live attenuated certainly is a big no when it comes to person on immunosuppressive therapy. So, Dr. Sheetal, this question is for you. How would you plan the vaccination in a patient on immunosuppressive therapy? So can for the sake of convenience, multiple vaccines be given on the same day? Let's say a patient has come from a far-flung area where the given vaccines may not be even available. So would you want to give them the influenza vaccine as well as Prevnar 20, because very soon we are going to be talking only about Prevnar 20. 23 is going to become obsolete very soon, hopefully, and certainly it'll make things easier. So there will be just one Prevnar 20 and annually one single dose of influenza. Can you give them on the same day for the matter of convenience? And before that, what is your take on the immunosuppressive protocol and the vaccination in the context of such a patient?
So coming to the second question first, I guess Dr. Mahajan in his talk has already elucidated upon the spacing of vaccination, and as he rightly pointed out, unless you are looking at two live vaccines, all the other combinations can be given at the same visit. So you can give a combination of a inactivated and a live vaccine, or two inactivated vaccines on the same day. You would make the note of giving it into two different sites in the same person. So that way they won't interfere, and you would probably identify if the patient has developed any local reaction. You would know for which vaccine it was. So yes, giving two vaccines on the same visit is definitely advised, doable, and that will definitely sort of make it more easy for that patient who's coming from far away. Coming to the question of immunosuppressants and vaccination, yes, if it is if you're dealing with a patient who is going to start or you're going to put him on an immunosuppressant, then it is always advisable that you vaccinate the patient before you can start the immunosuppression. So if it is a inactivated vaccine, you would give it at least 2 2 weeks prior to starting the immunosuppression, if that is clinically possible. If you can't do that, if the patient is already on an immunosuppression therapy, then there is no need to stop the immunosuppression therapy, obviously. You can still give the inactivated vaccine with the caveat that probably the seroconversion may not be as robust as to a person who is not on the immunosuppression therapy. Live vaccines obviously are a different issue altogether. So if a patient is on immunosuppressant and needs a live vaccination, then you have to basically judge the risks and benefits of giving a live vaccine to a person on immunosuppression. So that is going to be an individualized call to decide what was the real indication of the live vaccine and whether the benefits are going to outweigh the risk of giving that vaccine. So that is how I would probably put forward.
Very, very valid points, and I think we certainly have to individualize according to the needs of the patient. Certainly, we are not going to, as he has very rightly pointed out, stop their immunosuppression just so that we can give them the benefit of vaccination. We have to no textbook will tell you what to do next. So it's just your experience, is your adequate knowledge which will help you decide as to what to do the next. But important thing is, as we have repeatedly highlighted, to avoid live attenuated vaccines in patients who are on immunosuppressives. And I think the next part of the question, may I request Dr. Anupama, how would you manage vaccination in the context of kidney transplantation? Your patient is about to undergo, now he never has received any vaccine. Forget about hepatitis B, he's not even taken influenza. So how early? Let's say patient gives you 6 months of time before transplantation, or gives you just 15 days of time before transplantation, and how long after the transplantation can you resume the patient's vaccination? Dr. Anupama.
As you rightly said, that vaccination should be given very early in the stage of CKD, because the immune response and the rapid with the fall of the antibodies after vaccination do happen with these patients. However, when we have these naive patients just before transplant, there are issues there, especially as rightly said, the live vaccines are a problem. So we ideally advise that we give a live vaccine 4 weeks before the transplant happens, and the live and the inactivated vaccines can be given as close to 2 weeks before transplant. However, for influenza vaccine, which we there are bouts of infections which can happen subsequently after transplant as well. So it is advisable, if the patient is exposed to the influenza, the symptoms are happening in the near around, so we can give the influenza vaccine subsequently about a month after transplant. But live vaccines are absolute no. And if we want to give inactivated vaccines, they are preferably given 3 to 6 months after transplant, as Dr. Mahajana rightly said, because there is less intense immunosuppression in this period of time, and therefore one has to be cautious in the initial period of the post-transplant period.
And another thing which I had mentioned earlier as well, we find lots and lots of patients traveling to African countries where yellow fever is there, and it's mandatory for everyone traveling to those countries to undergo to receive vaccination against yellow fever. And we certainly have to tell the authorities that, look, our patients are different. Transplant patients should be exempted from receiving, and we need to give them certificate. But I think the knowledge is so very important. Another very common entity where we keep on getting a lot of requests from the patients and the families is that the person has been bitten by a dog. Even the scare is so much that even when you know it's a pet dog, has been fully vaccinated, but no one would want to take a risk, and there's always a fear of rabies. May I ask you, Dr. Aka? I mean, I'm sure you get a lot of such requests. So what should we do in the context of chronic kidney disease and a transplant patient as well? And that's very, very important for because, as I said earlier, it's a collective responsibility of all of us, not just the nephrologists. We are a handful. We are just about 2,500-3,000 across the country. So to manage the needs of 1.4 billion population across the country, we need the support of all those who have joined us today, and those many others who are there. Dr. Aka, over to you.
Yeah. So it's very interesting. Just today morning, we got a call on a medical query number about a post-transplant patient, 3 months, and he said, I've been bitten by a dog. So this is normal. We get these kind of queries, and generally they come on that emergency number from wherever the patient is. So yes, rabies vaccination is important both in CKD and post-transplant. So when it comes to C, the vaccine can be given both in CKD and transplant. This is an inactivated vaccine. It is recommended to give a fifth dose. So 0, 3, 17, and 28. So a fifth is recommended in post-transplant patient. And the recommendation also says that 14 days after you given the conventional is 0, 3, 7, 14, which is given in all patients. But post-transplant, we give a fifth dose. And recommendation is also that we should be repeating the antibody levels, which I have not done so far. I mean, I'm not aware where they are done, but that is the recommendation that it should be done after 14 days. And if they're not adequate, then another booster should be given.
Dr. Waka, there was disturbance in between. We lost you somewhere in between. Just for the sake of clarity, this is such a very important message. I would
Yeah.
request in a
So,
single line, if you could just repeat the important
yeah.
message.
So so CKD 03714, the usual conventional doses only have to be given. But in post-transplant, a fifth dose at day 28 is recommended for the immunocompromised patients, and levels to be checked 14 days after the last dose, that is the 28-day dose or the 14-day dose, whatever is being given. And if the levels are not adequate, then a single booster dose has been recommended. But yes, the same doses and the same schedule follows.
So again, so we don't have to be scared about this thing. So great. I'm sure we can certainly continue endlessly. There's so much to be learned from all of you, and I'm certainly quite happy to learn new things from all of you today as well. I'm sure those who have joined us today are also experiencing the same. Another message about tetanus toxoid is, I think, again, we don't as nephrologists come in the way of our patients receiving a tetanus toxoid. So whenever they have to be given, they should be given regardless of whether they are in the whatever stage of CKD or transplant status. So Dr. Mahajan, you have raised something very interesting. And I think till recently, we were only dreaming that our country also is going to have such expensive drug as eculizumab. Now, suddenly, so the doors have been opened, and you very rightly mentioned that we now have anti-complement therapies. We will be using, I know All India Institute is using a lot of them. You have access to, and then the great thing about our government is it is actually making it available to the most underprivileged population as well. So something which always was a dream, that yes, we can also effectively manage our patients with anti-complement therapy, that is with eculizumab. So with this comes in the need of effectively vaccinating them, and obviously they have not been vaccinated. So no one thinks about vaccinating people against meningococcus or H influenzae. So thank you very much for elaborating on those points. That well, we need to be mindful. And supposing it's a dire emergency where you have not had the time to pre-vaccinate these patients against pneumococcal or the encapsulated organisms, you can give them effective antibiotic prophylaxis, and then as and when the time permits, maybe you can go ahead with the vaccine. So it's just about knowing that these vaccines are available. Minactra is available, not very expensive, and I think even if it is 5,000 a single dose, it's not a bad bargain. Same about the Quadrivax, which again has the Tdap, which is tetanus, diphtheria, pertussis, as well as H influenzae. So you have two components that you can use Hib vaccination in these patients. So that makes your task rather easy, and at least your conscience is clear that you have not knowingly done any harm to the patients, where adequate knowledge about vaccinating them is important. So I think to summarize, and Dr. Mahajan, I will request you to one more time help me if I am missing it out on any important point, that for all our patients, the key messages today, ladies and gentlemen, would be that infectious diseases are the single most killers, at least in the developing nation as ours. Then the number two is that it is very difficult to convince our patients to get vaccinated because of so many reasons. It could be false notion, myths, or the cost factors. Another important thing is, if we are able to do that, it is actually is going to help everyone. So we are certainly going to be able to bring down the rate of infections, because it's one thing leading to another. One episode of pneumonia can actually precipitate an acute coronary event as well. One flu episode can play havoc with the heart as well. And if it is not the infections, we lose our patients to cardiovascular disease. I'm talking about people with more advanced chronic kidney disease. The sooner the better. We have good effective vaccines against some of the common diseases, starting from hepatitis B. So you certainly should not go with an idea that, look, hepatitis B is on the decline. But God forbid, if it ever happens to your patient, this certainly is a bad news, especially to those who have chronic kidney disease or who are post-transplant patients. So Dr. Mahajan, if anything, as a last minute, we have some great questions from in the chat box as well. People have been really interested in knowing, but many of these questions which are asked by our audience who had joined has already been addressed by the elite panelists today. So as a last concluding message, anything from your side, Dr. Mahajan, which certainly needs to be reiterated strongly.
So the one line message would be vaccinate as early as possible. And as I said, the first contact vaccination is probably the best vaccination. So as general physicians, as primary care physicians, I think so it's onus upon everyone. One, to identify patients with CKD, and number two, to vaccinate them as early as possible. Hepatitis B, pneumonia are two important things for which we have very potent vaccinations, and they usually are once in a lifetime vaccination. So it's again a good thing. Influenza is where at times the cost would take precedence over the cost benefit ratio. But other than that, I don't think so there is any query between hepatitis B and pneumococcal vaccine.
There are just a few more in the chat box, some very interesting ones, and I'll quickly request you to come out with your replies. So the question has been asked: in early stage CKD, do we already see reduced response to vaccines, or does it start only after eGFR has dropped to less than 30? Well, I think it starts even when the GFR has fallen to less than 60. So don't wait for that poor response to be seen in late stages of CKD. So again, taking a cue from what Dr. Mahajan just said, catch them young. Do it as early, as quickly as possible, and more effectively. If a patient has recently recovered from COVID-19 or other infectious diseases and already has high antibody levels, is vaccination still recommended immediately, or should we delay? Honestly speaking, I don't have answer to that. If someone from the panelists can take it up, and I think the question is, what if the patient develops COVID-19, because we know it's still there. It has not spared us. So what do we do in these kind of situations? Dr. Raka or Dr. Anupama, anyone? Yeah, normally, I think again the general dictum would be that you wait for some time after any illness. It could be
Yes, we should.
starting from flu and common flu to something as sinister as COVID-19. I think one would
Should
certainly
wait.
want to take a break. Is there any interaction between erythropoietin therapy and vaccine response? Should vaccines be scheduled on non-dialysis days for better immunogenicity? Well, another catch here in the context of dialysis is many of these vaccines are actually intramuscular, and on the day of the vaccine of the dialysis, we use heparin. So we would tend to refrain from giving them anything which is intramuscular. So from that kind of, although it makes it little impractical for the patient to come back, a person who's already on thrice a week dialysis will have to come the fourth time to the dialysis unit. But we can always say that they can take it from a place nearby, or but then it's preferred. So what is the recommended approach if documentation of past vaccination is not available at all? should we start full schedules or check titers first? I think Dr. Sheetal did allude to that even if when you're not clear, then I think the start, and I think you go by what the patients can actually relate to you. So if they're absolutely sure that they've received the full dose, then the best would be in the context of hepatitis B, check their antibody titers, and if they are found to be inadequate, then start all over again, as Dr. Raka had pointed out. So I think a whole lot of questions, as I said, many of these have actually already been tackled by the great presentation which Professor Mahajan had made, and as I said, I'm enjoying it. I'm learning, so I don't want to be any more selfish. So I think I'll allow Mr. Gaurav Khanna or Dr. Ankit to take over now before I keep on learning from the lead panelists and the speaker. Thank you very much once again to all my dear friends for this for accepting our invitation, and that too at a very short notice. Yeah.
Thank you, sir. Thank you. It is indeed my privilege to deliver the vote of thanks for today's session. I sincerely thanks Dr. Sandeep Mahajan for an excellent and insightful session, sir. My heartfelt gratitude goes to Dr. Anupama Kaul, Dr. Rarka Kosha, Dr. Sheetal Dangade, and Dr. Girish G. Reddy for their valuable contributions and enriched this program. A special thanks to our esteemed course director, Professor Dr. Dinesh Kula, sir, for the smooth and seamless conduction of Nephro Live 10 and for sharing his expert opinion throughout the event, sir. We are proud to witness over more than 1,800 participants joining us today, which truly reflects the success of this event. Finally, I would like to extend my appreciation to all the esteemed delegates for taking time out for their busy schedule and attending the webinar. So thank you very much, sir, for your time. And we eagerly look forward to welcoming you on our future session. Thank you once again, sir. And good night to you, sir.
Is one I would want to reiterate one more time. An absolutely, totally selfless initiative, no branding at all. It's all science and science, which we'll find here. Without any personal motives by the pharmaceutical company.
Sir, I would like to only say that we are for science, sir.
Yeah.